Okay, so this will let people come in and we'll see who all, there we go. Okay. Have people waiting in the wings while we're figuring out our technology. It's always something, right?
Yeah.
Yeah.
I still say I'm like 3 years into the pandemic. I'm still like, unmute yourself. Like, oh.
You ever seen that? It's like a little video where it's like 2020, oh, you're muted, unmute yourself. And then 2021, it's like, come on, you're come on. And then in 2023, they're like, oh my gosh.
Mine is I still don't like when I'm trying to sometimes because I have multiple screens and slides and then the like speaker setting view, I still am like, oh, I don't know how to resolve that. But anyways.
Yeah. So I think we've got most everyone in here. I know probably several of you were sitting in the waiting room while we were getting some things sorted out. And it looks like the rush of that holding has probably come through now. So we are just about ready to get started here. Dr. Dietz needed to reboot his system. So he will be joining back in here in just a minute. Just want to thank everyone for joining us wherever you are in the world. This is one of those topics that I feel like has been long anticipated by the LDS community and by our presenters, Dr. Dietz and Gretchen MacCarrick. I know we've been talking about it for a long time, and here we are, 15, 16 years in, and it's time to start looking back, looking forward again. So, while we wait for Dr. Dietz to join us, do you have anything you want to like kind of intro that with, Gretchen, or do we want to wait?
Yeah, can you give us, I can't quite share a screen yet, so I can give us.
Of course.
Will this be on YouTube? Yes, I promise it will. They always are. Okay.
Yes, this will be recorded. It's being recorded, and we will be posting it on YouTube, and I will be sending out a link to actually both of this week's webinars, hopefully tomorrow, if I can get this one loaded back up in time. So
awesome.
Yeah, I know we've had some recently that we were not able to share back out on links because we did there have been several based on research that where the research has not yet been published. So while in the past we were always recording and sending back out, some of those need to wait until that research is finalized. So
great.
Yeah.
Cool. Well, now that we have our team here, so thanks, Angela. We're really excited to be here today to talk about the guidelines, kind of what we knew then and moving forward. And the motivation for this is that, as you may or may not know, I guess, in Belgium later this month, there's going to be a European meeting. So hopefully we'll be able to meet some of our European friends at that meeting that Dr. Loeys is putting on. And there's a patient part of it, and then there is kind of a research clinician day as well. And part of our task on that second day is to think about the Loeys-Dietz guidelines and kind of research priorities from a clinical perspective, and think about what does the future hold, what should we be doing. So we wanted to use this opportunity to kind of bring the guidelines that were written in 2014 to our patients and kind of review what the guidelines say in terms of different features, the management of the different features, but then have a really interactive discussion. So make sure you use your questions, make sure you use the chat function to really hear from you about what questions you have that we should really be looking into the literature or thinking about addressing in the guidelines moving forward, in anticipation that we'll be writing them, gosh, what did Angela say, like almost 10 years later. So again, this is the primer that many specialists, most of them from Johns Hopkins, because back in the day we had the most experience with Loeys-Dietz. So our specialists came together to write these guidelines back in 2014. And back in the day, we really had discovered only 4 types of Loeys-Dietz syndrome back then: TGF-br1 and 2, types 1 and 2, SMAD3, and TGF-beta 2. So clearly many of you come with Loeys-Dietz types 5 and 6 caused by variants in TGF-beta 3 and SMAD2. So we need to kind of address the differences and the similarities in the newer types of Loeys-Dietz syndrome. And I think an important concept to address here is in some of the Loeys-Dietz types, probably 4, 5, and 6, there does tend to be a higher incidence of something called non-penetrance. And so you can see these two kind of family history or pedigrees here. Just to interpret them, they're 3 generations. So you can see the square married to the circle, the man and the woman on the topmost of these 2 charts. And then you can see going down on the left where it's blacked out, that is referring to autosomal dominant inheritance, right? Which we know is the inheritance pattern for Loeys-Dietz syndrome. And you can see that the mother passes it on to one of her sons, and the sons pass it on to one of the daughters. And the black represents that all of them are basically showing the features of the condition. And we know in Loeys-Dietz syndrome, especially in some of the newer types, there can be what's called non-penetrance. So this is a chart on the right where you can see the mother on the top generation also passes it on to that son on the right side because his daughter shows symptoms, but he's really asymptomatic. So in Loeys-Dietz syndrome might not show aortic dilation. And something we want to think about in the newer guidelines and we get questions about is like, what if you're that person in the middle? What if you have a family history of people with aortic disease? You carry the Loeys-Dietz variant, but you don't have aortic disease yourself. What should you think about treatment and surveillance? And so kind of a late breaking also research discovery that we wanted to bring forward is that there was a paper earlier this year that described a possible new Loeys-Dietz gene. So this is not clinically available yet. So, you know, many of you probably had what's called an aneurysm panel for genetic testing where they look for DNA variants in about 30 to 40 genes associated with Loeys-Dietz and Marfan and aortopathy. So it's not on those panels yet. But this paper back in March described kind of a Loeys-Dietz phenotype in a gene called PMEPA1. And so you can see on the family histories, the pedigrees on the right, the individuals that are affected are in red. And so you can see it does show an autosomal dominant inheritance pattern, both seen in like singleton cases, but also in generational families. There wasn't a full clinical kind of feature listed for all these individuals, but they showed a Marfanoid habitus with a long face, tall, thin stature, striae, or stretch marks, flat feet, and aortic aneurysm. But this gene interacts with the SMADs, and so really is a regulator of the transforming growth factor beta pathway, which is, we know, the pathway for Loeys-Dietz syndrome. So I think, okay, I'll go into one more slide and then pass it to Dr. Dietz. So one of the big things that differentiated Loeys-Dietz syndrome from Marfan syndrome in the very beginning was this recognition, right, that aortic diameters could show dissections or tears at smaller diameters than Marfan syndrome, necessitating the need for potentially earlier surgery at smaller dimensions. And so in 2014, when we were really studying types 1 and 2, we were setting thresholds around 4 centimeters, or depending upon how fast the aorta was growing, and really wanting to do surgery in younger kids once the valve reached 2 centimeters. And most of those guidelines would still be in place. However, there is a greater appreciation in Loeys-Dietz syndrome for more individualization and personalized decision making. So we really want to take into account what gene is impacted, perhaps what is your specific variant, and what can we learn from other family members. How fast is the aorta growing? What can we learn from your family members? Was there early dissection? Did people not have problems until later in life? How does that impact it? To really kind of better fine tune guidelines for surgery for you and your individual families. Something that we do need to do when we're thinking about updating our guidelines, however, is look in the literature to see kind of what variants might be associated with aortic dissections at those smaller dimensions, because maybe they need a little bit more aggressive surgical guidelines. And then also, you know, the surgery that most people get for aortic aneurysms is a valve sparing procedure that might replace the root and up into the ascending, but really kind of stops there before it's going into the arch. And so potentially what we might learn is that, are there some variants? Are there some types of Loeys-Dietz syndrome gene mutations? Are there some families that maybe tell us that instead of just doing that root repair, we should go a little bit farther. Some of you have might had something called like a hemi-arch repair, where they've put graft material into the root, the ascending, but kind of gone over a little bit farther into the arch. And maybe that should be the first surgery for some people. And so that's something we definitely want to look into. Again, I will say, if you guys have questions or thoughts, make sure to put them in the chat or the questions section as well, because I know we're kind of talking really fast through these things. I think Dr. Dietz is going to talk a little bit more about some of the pathway information quickly.
So back 10 years ago, we knew that Marfan syndrome related to alterations in the activity of a molecule called TGF-beta. That's a mechanism by which cells talk to themselves or talk to each other. The evidence was that by some incompletely explained mechanism, there appeared to be too much TGF-beta activity within the aortic wall. We first learned this in Marfan syndrome, but if we go to the next slide, we also were able to infer from this, from the high activity of TGF-beta activity that we were seeing, that the medication losartan might be protective. That's based upon the ability of losartan to blunt or attenuate TGF-beta activity within the aortic wall. At that time, we had done studies in mouse models of Marfan syndrome that revealed that losartan was remarkably protective over the long term. The data from the animal model of Marfan syndrome also showed that beta blockers such as atenolol or propranolol also afforded some protection. So we were starting to be able, on the basis of animal studies, to suggest that beta blockers and or angiotensin receptor blockers such as losartan might be useful in people with Marfan syndrome. If we go to the next slide, we were lacking very detailed information about the performance of these medications in people with connective tissue disorders. There were a variety of clinical trials done in Marfan syndrome that were suggesting that beta blockers and angiotensin receptor blockers might have some protective effect. But there still was some ambiguity about which medications worked and which medication was better. So more recently, a number of investigators have performed what's called a meta-analysis. They take the data or the information from all the available clinical trials and they combine the data to increase the power, to increase the ability to make conclusions. And both of these meta-analyses confirmed that angiotensin receptor blockers were protective in people with Marfan syndrome. The most recent meta-analysis, the one that was most rigorously performed, documented that in Marfan syndrome, angiotensin receptor blockers such as losartan overall cut the rate of growth of the aorta in half. And the effect was even bigger if someone had an identified mutation in the Marfan gene, in the FBN1 gene. So that put us on much firmer ground regarding the recommendation that angiotensin receptor blockers and or beta blockers do have therapeutic effects in Marfan syndrome. We still, on the basis of animal studies that have been performed since the time of the last recommendation or last guideline paper, we now have better data for mouse models of Loeys-Dietz syndrome. I think that's what's on the next slide. No, I'm sorry. This slide illustrated a equally important point for people with Marfan syndrome. We had learned that losartan could slow the rate of growth, but an important question was, can the medication delay or prevent the critical events that happen in people with Marfan syndrome, such as aortic tear or aortic surgery? This was addressed in a long-term follow-up of a clinical trial that was performed by investigators in the Netherlands. And they nicely demonstrated not only that the protective effect of losartan was maintained over time in the study up to 9 years, but that also people treated with losartan or similar medications had decreased rates of reoperation on the aorta, operation beyond the aortic root, aortic tear, or death due to any cause. So not only was losartan slowing the rate of aortic growth in people with Marfan syndrome, but also delaying and hopefully over the longer term preventing these important clinical events. Next slide. So we had learned a lot about Marfan syndrome and its relationship to TGF-beta. Loeys-Dietz syndrome, we now know, has 6 different identified genes. All of them relate directly to the TGF-beta signaling cascade that's shown on the right. If you go to the next or click the next panel, you can see the obvious clinical overlap between people with Loeys-Dietz syndrome and people with Marfan syndrome with regard to facial features, with regard to long fingers, for example, with regard to widening of the base of the aorta. We also learned since the guidelines were published that another condition, next click, called Sprintzen-Goldberg syndrome, which also has obvious overlap with Marfan syndrome and Loeys-Dietz syndrome, was also caused by alterations in a modulator of TGF-beta activity, a molecule called SCI. So on that basis, we felt comfortable suggesting, not with proof, but suggesting that therapies that were effective for Marfan syndrome might be effective for Loeys-Dietz syndrome and other disorders. Next slide. So Elena McFarlane, another investigator at Johns Hopkins who was in my lab at the time, did a beautiful job of assessing mouse models of Loeys-Dietz syndrome. These mice show very dramatic aortic root aneurysms, as we see in Loeys-Dietz syndrome. Also showed the signature for high TGF-beta activity, and for the first time allowed us to directly test the hypothesis that medications such as losartan would also be protective in this condition. As you see on the right, mice with a Loeys-Dietz mutation, shown by the orange boxes, have larger aortic roots than mice that don't have Loeys-Dietz syndrome. If you treat them with losartan, the aortic growth rate is completely normalized. And that's very different from the effect of treating with a beta blocker such as propranolol or atenolol, where we really didn't see any evidence of a protective effect. So starting to give us greater confidence that our initial recommendation that medications such as losartan be considered for Loeys-Dietz syndrome truly had experimental evidence. If we go to the next slide, we're now understanding exactly why medications like losartan work in these conditions. Again, by work that was done by Elena McFarlane, we've learned that cells within the aortic root, so-called second heart field derived cells, which are colored in orange, are sensing the effect of the Loeys-Dietz syndrome mutations. And in response to that sensed abnormality, they're producing lots of TGF-beta, which is shown by these little purple starbursts that goes on to stimulate neighboring cells that are colored in green, which derive from a different embryonic origin called the cardiac neural crest. What we learned is that the excessive production of TGF-beta by the second heart field cells, by these orange cells, is completely dependent upon the molecule, the receptor that is blocked by losartan. So if you treat these cells with losartan, they no longer have the ability to produce too much TGF-beta. And in mouse models, that's the mechanism for prevention of aneurysms to form. So now I think we feel more confident going into the next round of guidelines to say that drugs such as angiotensin receptor blockers, losartan, irbesartan, or other family members hold strong promise in the treatment of Loeys-Dietz syndrome. We would also advocate the potential additional use of beta blockers such as atenolol or propranolol. So that will be part of the next updated guidelines. I think we're going to go back to you now, Gretchen.
So in terms of, I don't know if you have the ability, but I've been trying to answer some of the questions in chats if you want to take a look, Dr. Dietz, but if not, no worries, we'll get to them at the end. In terms of vascular imaging guidelines, these have generally remained the same. In the very beginning, we were recommending head to pelvis imaging at baseline, as well as imaging about every 2 years. Of course, if there is any aneurysm or dissection found, we rely on our colleagues in the vascular surgery and cerebrovascular space to help us figure out if those should be imaged on a yearly basis. We continue to kind of balance the pros and cons of MRA versus CTA imaging, and I know we get a lot of questions about that. Both of them are injecting dye and giving us the ability to look at the diameters of blood vessels. MRAs take a little bit longer, and they might be a little bit more fuzzy when it comes to very small blood vessels, like in your brain or some of the blood vessels going to your GI system, but they don't have radiation associated with it. And so that is our preference, because we don't want to be adding radiation every a few years. That can have a cumulative effect over a lifetime. But CTA is what everyone would get in case of an emergency. So if you present to a hospital with emergent pain, a CTA is performed. It's very clear for small blood vessels. It's very fast. But again, we don't want to be repeating this over time because of the radiation risk. And so some of you have probably seen this slide before, but what one of our goals is to actually look at like what different arteries and portions of the aorta are involved in different types of Loeys-Dietz syndrome. And the last time I looked at this was probably about a year ago, but kind of the baseline is when it comes to the cerebrovasculature, all types of Loeys-Dietz syndrome have shown aneurysms at a rate of about 10 to 30% actually. In all different types of Loeys-Dietz syndrome. Many of these are just kind of watch and manage and wait and don't need intervention, but we have noted aneurysms in all types of Loeys-Dietz in the head and the neck. And, bottom line is that in all types of Loeys-Dietz syndrome, we can see aneurysms throughout the head to the pelvis. So we do think head to pelvis imaging is indicated. Whether for everyone in every scenario it needs to be 2 years, that's still a little bit of an unknown question. Some questions have come up about, well, what about in your legs? What about aneurysms there? They have been reported in the literature, especially aneurysms kind of behind your knees called popliteal. But my understanding from those is a lot of times you have symptoms. You can feel like a bulge, or you can feel pulsations in them. And so you're going to get visualization that it's an enlarged artery. So that's why we don't image there routinely. In our 2014 guidelines, we didn't really address any specific variant information. And so that means that, we have these 6 different types of Loeys-Dietz syndrome with gene variants or gene DNA changes within that gene. But what we do realize is that there are a few recurrent, very aggressive gene changes that we know can lead to more aggressive disease. So for instance, in TGFBR2, usually in new spontaneous cases of Loeys-Dietz syndrome, this specific mutation or variant called ARG528, either a histine or a cysteine change, this specific variant, we see very aggressive disease in childhood or in teenage years. And so we really want to get the word out that if this mutation or this variant is happening, we really need to watch these kids more aggressively and maybe image them, see them more frequently, because they show aneurysm growth that can happen pretty quickly, and they can show tears of the aorta, especially in the descending, that lower portion of the candy cane. They can show tears there even in childhood. We have the same experience with this specific variant, threonine 200 isoleucine, in the gene TGFBR1, where we've seen poor outcomes in children. So we want to assess the literature and the experience of other providers to see, are there other gene mutations that kind of trigger us to watch out, to watch these kids more aggressively and earlier. Just as a reminder, there is overlapping severity in all different types of Loeys-Dietz syndrome. Kind of big picture in general, what we kind of say is TGFBR1 and 2 tend to, as a whole, be on the more aggressive end of the spectrum, with SMAD3 kind of overlapping in the middle, and then milder on TGF-beta 2 and SMAD2, but this is definitely not a hard and fast rule. And we have some families that overlap into the more severe category in Loeys-Dietz 5 and 6, and vice versa with TGFBR1 and 2. In terms of cardiovascular management, what we would say and continue to say is that people should be getting at least yearly echocardiograms. Clearly, we're doing that a little bit more frequently in childhood for individuals who are severely affected or having kind of close to surgical threshold aortas. We clearly want to avoid hypertension, putting people on blood pressure medications. One thing that we must say about blood pressure medications is it's really important to take these receptor blocker medications, both ARBs and beta blockers, really, really consistently. So because of how it impacts those receptors, if you're going off the medication for a week and then going back on, or going on vacation and forgetting to take it, it can actually be more harmful than not being on the medication. You all are aware, I've seen some questions there about exercise restrictions. So as a general reminder, we want you to be a healthy person, exercise for fun and in moderation, avoiding those heavy weightlifting and kind of Valsalva movements where you really have to strain and close off your windpipe are to be avoided. Avoiding exercising to exhaustion. So run as a family, do 5Ks for fun, don't run them to get personal records. And in the 2014 guidelines, we did address that congenital heart disease, misspelling, is typically managed per typical protocols. We do see increased prevalence of bicuspid aortic valve, which usually is not that significant, but comes into account when we're thinking about what kind of surgery to do for the aorta. So we know something that we need to be looking into is that as our population is aging, we do see some more instances of arrhythmias and cardiomyopathies, and so we really want to pay attention to what is happening to our adults as they're getting older. Dr. Dietz, you're going to talk about some of the blood pressure medication research as well.
Yeah, so as we've talked about, we and other groups are trying to understand what medications might be good for someone with a vascular connective tissue disorder. A different question that I think can be equally important is what medications or other interventions should be avoided in someone with a vascular connective tissue disorder. A number of years ago, again using mouse models of Marfan syndrome, We showed that treatment with a class of blood pressure medications called CCBs, or calcium channel blockers, unexpectedly led to very rapid growth of the proximal portions of the aorta and early tear of the aorta. In collaboration with a group of investigators that had formed a registry called GenTech, we asked if there was any suggestion that medications in this calcium channel blocker group also imposed risk in people with Marfan syndrome. And the answer was yes, that there was clear evidence that people in this registry that were taking calcium channel blockers showed a higher risk of either aortic dissection or the need for aortic surgery during the follow-up period. We also began to investigate whether this might extend to other vascular connective tissue disorders. And again, the answer was yes, that even in people without Marfan syndrome, we were seeing the suggestion of a greater risk of aortic dissection or aortic surgery in people taking calcium channel blockers. Next slide. So we have now directly tested this in mouse models of Loeys-Dietz syndrome, here using a calcium channel blocker, a common one called amlodipine. Importantly, in these studies, it didn't matter which calcium channel blocker you used. They all appear to have this detrimental effect. But clearly in the mice with Loeys-Dietz syndrome shown on the right, the addition of a calcium channel blocker caused much more rapid growth of the aorta, here looking at the aortic root. But if we go to the next slide, also further up the aorta in a segment called the ascending aorta, calcium channel blockers also aggravated disease. Not only did they cause the aorta to get bigger faster, but they also cause the aorta to tear earlier. So on this basis, I think that we could extend the general recommendation for people with Loeys-Dietz syndrome that calcium channel blockers should be avoided unless they're absolutely needed to treat some specific serious condition. If they are the only medication that's effective in lowering a dangerously high blood pressure, then I think we would still recommend their use. But if there are alternatives, and in most people there are many good alternatives, we would recommend avoidance of calcium channel blockers.
And Dr. Dietz, there's a question that I just don't know the answer to in the chat. Is this just to calcium channel blockers that are in this amlodipine pathway, or does it include diltiazem and verapamil too?
Yes, so we tried multiple calcium channel blockers in many different classes, and they all showed this detrimental effect on aortic growth. So we think it's true of the class of medications called calcium channel blockers, not just specific calcium channel blockers. So there are other medications that we suggested avoiding back in 2014. One was a class of medications commonly used to treat migraine headaches called triptans. These medications are quite good at stopping a migraine headache that's already started, but they work by causing blood vessels to tighten, so-called vasoconstrictors. And the general recommendation is that this class of medication should be avoided in people with vascular disease. We believe that that extends to people with Loeys-Dietz syndrome. Fortunately, there are many new classes of medications that are effective at both preventing migraine headaches and also stopping a migraine headache that's also started. So we do believe that there are good and safe alternatives. Decongestants, anything meant to dry out the mucous membranes, also have some stimulatory effect on the cardiovascular system that can include an increase in heart rate and blood pressure. We're not worried if someone occasionally uses a decongestant, for example, if they have a bad cold for a couple of days. But if someone develops a pattern of regular use of decongestants, for example, for allergies during the whole allergy season, we think that this stimulatory effect on the cardiovascular system could be problematic. So we would suggest avoiding prolonged use of decongestants. There is a class of antibiotics called fluoroquinolones. Scott Lemaire and colleagues at Baylor have extensively studied this class of antibiotics in people with, in mouse models with connective tissue disorders. It is known that this class of antibiotics can have effects on the integrity of connective tissue in general, and that this has caused problems in people. There are now studies to suggest that the problems that can be seen in people that take this class of antibiotics can include more rapid growth and potentially tear of the aorta. So the general recommendation, once again, is that this class of antibiotics should be avoided if there are good alternatives. If you have a life-threatening infection and the only antibiotic that will work to treat the infection is a fluoroquinolone, then the drugs should still be used. But if there are alternatives, they should be used instead.
One other question, just in terms of meds that came up, if you want to comment on like the use of ADHD stimulant medication.
That's a great question. So there are many different types of medications that are used for attention deficit disorder with or without hyperactivity, so-called ADHD. Some of those medications are non-stimulants. They don't have a stimulatory effect on the central nervous system or the cardiovascular system. Other medications that are commonly used to treat ADHD are stimulant medications and can have effects on the cardiovascular system. Our belief and our general recommendation now over many years has been that the treatment of ADHD is very important to allow people to learn and to socialize and to do many important things. So we do think that the perhaps non-stimulant medication should be tried first. If they are effective, fine. If they're not effective, then we do recommend advancing to stimulant medications as long as the cardiovascular status is being carefully monitored. We would, for example, check the heart rate and blood pressure when someone's first starting on a stimulant medication, and also as the dose is being increased. If a rise in heart rate or blood pressure is seen, we think it's possible to compensate by using higher doses of other cardiovascular medications, such as angiotensin receptor blockers and or beta blockers. So we would support the use of stimulant medication for people that need that class to adequately treat ADHD.
Thank you. And thank you, everyone. We're falling behind in all your questions online and your chats, but keep them coming. It's great. So in terms of vascular surgery as well, we really want to make sure in the upcoming guidelines that we get our vascular surgery colleagues involved. This is a slide, again, some of you might have seen last year when we talked with Dr. Black, but there are kind of practice guidelines, especially surrounding the visceral or the arteries in the abdomen that are going to the GI tract, and kind of what dimensions surgical intervention is performed at. And we, in general, use these guidelines as well for Loeys-Dietz syndrome. But having a dissection in a blood vessel and or rapid growth are also considerations that might alter these. So in the newer guidelines, we also want to make sure that we expand our cerebrovascular section now that we have a little bit more information on that, and making sure that we're including more information about these visceral artery surgical thresholds. In terms of orthopedics, again, when we were focused and had our knowledge mainly about Loeys-Dietz types 1 and 2, we did see that many patients had cervical spine instability. So the spine and the neck, where you kind of extend and flex your neck. In some individuals, there can be some malformations, and sometimes that's not a problem, but if they're quite severe, they can impact surgical intervention, or when doing any type of bending, they could impinge upon the spinal canal. And so some kids need surgery on this. And so we did recommend baseline flexion extension x-rays. We're still learning about whether we should be doing this in all types of Loeys-Dietz syndrome or whether it's more prevalent in some, so still learning about that. And also, you know, we discussed in the original guidelines that most of the operations for club foot or knee surgeries or other type of replacement joints in older individuals should be done per typical protocols. But we really want to make sure that we're assessing the literature, the case reports, to see if there's any new or additional information we should be using when it comes to repair of the chest wall, pectus deformities, scoliosis. Spondylolisthesis is kind of slippage of the spine, usually in the lumbar area, that sometimes needs surgical fixation, C-spine surgeries. And I think a lot of people have questions about when it comes to foot, ankle, knee repairs, and maybe loose ligaments or flat feet. So we really want to assess what the newest knowledge is in terms of that orthopedic care. We do know that a subset can also have bone fragility, leading to increased fractures or longer recovery times with scoliosis surgery or rotting or fixation surgeries. So consider expanding how we work up our patients with skeletal issues, including DEXA scans or what blood work should be performed, and talking a little bit about treatments like bisphosphonates, etc. And again, assessing the prevalence of cervical spine malformations and some of the newer types of Loeys-Dietz syndrome. In terms of pregnancy, I don't know that there's a heck of a lot of new changes either since 2024 or 2014. Something to be aware of is that the angiotensin receptor blockers that Dr. Dietz was describing can be teratogenic or harmful to the fetus in a pregnancy. So we really want to plan out those pregnancies and down titrate individuals off the ARB prior to pursuing a pregnancy. And we usually manage people on a beta blocker. We try to do full vascular imaging prior to a pregnancy to make sure everyone is safe, but to also assess for the presence of dural ectasia. So dural ectasia is the dura is kind of the sac around the spinal canal, and so in a lot of people with Loeys-Dietz syndrome or connective tissue disorders in general, that sac can kind of protrude out and a little bit in the lumbar area. And so we just want to have a good anatomy for our OBGYN colleagues in case they're doing any epidurals to really know the anatomy of the spinal area. We usually echo in every trimester, as well as in the postpartum period, and really recommend being followed up by a high-risk OBGYN. For our update, we really want to review the literature on pregnancies in Loeys-Dietz syndrome. We know that many women have had successful pregnancies, but our next slide will kind of go through some outcomes. And it's just challenging to predict who might run into problems and who wouldn't. The new American Heart Guidelines suggest that perhaps, at least in Marfan syndrome, women can get up to having a 4.5 centimeter aorta in pregnancy. And we need to assess whether that may be applicable to Loeys-Dietz syndrome or not. Consider whether there is any new information or what should be added in terms of gynecological information, and really assess what we know about postpartum complications that might impact how we talk about breastfeeding safely in Loeys-Dietz syndrome. So many of these, some of these women you may know from the community, but kind of the takeaway from Loeys-Dietz and pregnancy is that you know, there are many women who have had multiple pregnancies who have gotten through them safely, but there's also women who have had problems in their first pregnancy or their third pregnancy. And it's really hard to have that crystal ball and predict who may run into problems and who may not. So we just really recommend careful planning of a pregnancy with your entire cardiac, genetic, OBGYN team. So I know Tony is taking notes for us, Dr. Guerrero, and if he has anything to jump in, but we do know, or we have appreciated, going back to 2014, that there is an increased evidence of allergic disease in patients with Loeys-Dietz syndrome. And so I don't think we have a tremendous amount to add in terms of management. However, most of our data comes from types 1 and 2. And so we thank you to everyone who has participated in the allergy and GI research at the NIH for their part of their natural history study. So we really want to depend upon our colleagues there to see if there's any new information that we should be adding in terms of allergic disease. We do know that food allergens can run from causing eczema and mild skin reactions to quite life-threatening anaphylactic responses. And so food allergens are really treated by food avoidance and other typical protocols. You know, many people are given EpiPens in case of exposure, in case of emergency. And we would agree if someone is having closing of the windpipe and not being able to breathe if exposed to their allergen, an EpiPen should be used. But if someone is just having a mild skin reaction or they want to use the EpiPen if there may have been an exposure, that we would proceed with caution and maybe use Benadryl or some other form of treatment before jumping to the EpiPen, because it increases and spikes up your blood pressure. Eczema can also be treated with typical creams that are used in kind of general eczema. Along with the allergic disease, we can see a lot of sinusitis and ear infections. So making sure that we're really aggressively treating asthma and sinus and ear infections. And we talked about the decongestants. Okay. Same thing for gastroenterology and nutrition for Loeys-Dietz syndrome. We do follow the growth of our patients, especially our young kiddos, very closely, especially if someone is looking at a surgery in the near future. We really want to optimize their growth and their weight, because kids tend to kind of plateau and lose weight after surgery. So we want to make sure that they're in optimal place. If there are really if there are big problems with failure to thrive or food allergies, many of our kids with allergic disease do require G-tubes to help get the caloric intake that they need. We are periodically monitoring calcium and vitamin D, and we're using typical protocols for that. So we really want to make sure that we're reviewing the literature and working with our GI colleagues for any new GI updates. And maybe, Dr. Dietz, I'll just kick to you for the one thing, because it comes up routinely about risk of cancers and Loeys-Dietz syndrome and kind of interpretation of the literature there.
Sure. So when we first identified Loeys-Dietz syndrome and recognized that it was caused by mutations in the TGF-beta signaling pathway, we had some concern that might also cause people to have increased risk for certain cancers, especially certain gastrointestinal cancers like colon cancer. The reason for that is that mutations in these same genes had been identified in the tumors of people with colon cancer that was identified in their 60s or 70s or 80s. Importantly, in the colon cancer, there are many different DNA changes that have occurred, not just a change in one of these TGF-beta genes. We monitored our families carefully, and I have to say that we were greatly relieved not to see an increased incidence of cancer in people with Loeys-Dietz syndrome. There might be some suggestion that if someone with Loeys-Dietz syndrome has certain types of cancer for a different reason, unrelated to Loeys-Dietz syndrome, that their cancer might be a little more aggressive, but we're still not ready to even make that conclusion. In general, people with Loeys-Dietz syndrome should follow standard guidelines regarding when to start, for example, having surveillance procedures done to look for cancer. It would parallel what occurs in the general population, for example, regarding colonoscopy. The good news is that by and large, people with Loeys-Dietz syndrome do not have to worry about an increased cancer risk.
Thanks.
Sure.
Do you want to say anything about this? Or this is kind of an outline, you know, when we look at Loeys-Dietz syndrome compared to Marfan syndrome, compared to Sprintzen-Goldberg syndrome, which Dr. Dietz reviewed during his kind of pathology slides. It kind of has an outline of different features that we see that are unique to Loeys-Dietz syndrome compared to the others. And I know everyone always has questions about, like, we need this chart in terms of breaking down the different type of Loeys-Dietz syndrome. So hopefully we'll get to that account or get to that task as well. But any specific comments on anything you want to pull out here?
Yeah, I mean, this chart is in evolution. We continue to learn about the different flavors of Loeys-Dietz syndrome and also the other vascular connective tissue disorders included on this chart. This adds to our incentive to develop a comprehensive database of people with Loeys-Dietz syndrome that clinicians and families throughout the world can contribute to. Hopefully, what we anticipate in the future is that this will be will reflect a very detailed analysis, and that the patterns of involvement of different parts of the body in different forms of Loeys-Dietz syndrome will also help us to predict the future for affected individuals. That, where we can say, well, if somebody has feature A and B and C, that we can predict that they're at higher risk for a complication, and that we could take action to prevent that complication rather than waiting for it to develop and try to treat it or address it afterward. We're looking to you, to all the families with Loeys-Dietz syndrome, to help us add granularity to this chart and to begin the process of being able to develop predictive algorithms that will help us take better care of LDS families.
Great. And then we just want to end with a few slides of kind of like all the other stuff. And so we know that in patients with Loeys-Dietz syndrome, there can be dental anomalies that can include clearly like malocclusion and crowdedness, but also poor tooth enamel and difficulties with tooth intervention, especially as children. So we really want to update the guidelines with what our dental colleagues at the NIH have reported. So some of our patients, and there have been some studies on hearing loss, especially associated with tympanic membrane ruptures or cholesteatomas. So we want to update information on that. Looking at the literature, some patients need intervention because of cleft palate or jaw surgeries if they have kind of a recessed jaw to make more space. Is there any information about those type of surgeries and complications that we have to think about? Expand on ocular disease. We have another slide in terms of ophthalmology, but kind of expand that session. Again, assess C-spine issues. Are these occurring in the newer types of Loeys-Dietz syndrome? Duralactasia management. Duralactasia is very common in Loeys-Dietz syndrome and connective tissue disorders. It's often asymptomatic, but if it is symptomatic, it can cause a lot of pain, and intervention is very controversial and difficult to see if it would work or not work, and outcomes. So kind of assessing any new information when it comes to dural ectasia care. And then a lot of you have questions too about headaches. And so trying to assess what information we can get into your hands about headache management. In 2014, we did talk about kind of neurological issues. In the first reports of Loeys-Dietz syndrome, we had some cases of individuals with intellectual disability. However, we think this is really related to undiagnosed hydrocephalus, or fluid buildup in the ventricles that puts pressure on the brain that's causing increased intracranial pressure, and that the intellectual disability is really kind of a result of those features. Because as you know, and as we appreciate, our Loeys-Dietz population are the smartest, funniest, wittiest, most creative people out there. So we think that there really isn't intellectual disability as part of Loeys-Dietz syndrome. Hydrocephalus is rare. Dural ectasia, like we said, is somewhat common, but often asymptomatic. There was a question there about spontaneous CSF leaks. I don't know, Dr. Dietz, I don't think of spontaneous CSF leaks very commonly. I think we can see them more frequently with spinal interventions as a complication after spinal surgery. There can be, slower leaks impacting headaches, but I don't know about your thoughts on spontaneous CSF leaks.
So fortunately, spontaneous CSF leaks are rare, but they can occur in people with Loeys-Dietz syndrome and Marfan syndrome and other connective tissue disorders. If someone has a unexplainned, sudden onset, horrible headache that's very positional, that is greatly aggravated by a change in position, such as sitting up from a lying position, then and that's going on for a long time, then a spontaneous cerebral spinal fluid leak should be considered. There are imaging studies that can help to try to diagnose whether a spontaneous CSF leak has happened. And there are also some interventions that can be performed to treat a CSF leak and relieve the headache. So it's something that should not be top on people's minds, but something that is possible.
Thanks. Some of our patients can also, if they have a dissection in their vertebral or carotids, can have strokes. And so making sure that, again, we're expanding on that cerebrovascular section and stroke management. And I see everyone is like, address headaches, address headaches. We realize that this can be quite an issue. I'm putting together another talk. Hopefully we'll get that next year on kind of what to think about when you have headaches and how to describe them and kind of the different types of headaches. So hopefully we'll have a little bit more education on that too. In terms of eye disease, we do see retinal detachment. I know some of your questions are, what's common, what's not, what's rare, what do I have to be worried about? So we would say that a retinal detachment is relatively rare. However, when we do see it in childhood, it can be a somewhat severe and bilateral disease. So there's some other gene modifier or cohort going on in those kids, but often what we see it is kind of general population risk in adults. Cataracts are really a non-issue, at least like congenital. As our population is aging, we'll come into the general population risk. Myopia or nearsightedness, common. Exotropia, common. Kind of eye wandering. Some young kids need patching or surgical interventions to kind of straighten out their eye muscles. And there are reports of retinal tortuosity, but I don't think it's well described. I don't know if it causes issues, but has been described in the literature. From a lung pulmonary perspective, we do know that there is restrictive lung disease, that sleep apnea may be underdiagnosed in our population. So again, in terms of like general fatigue and people having issues or poor sleep, practicing good sleep hygiene and making sure that if there is any snoring, if there is any daytime tiredness, that you're getting a sleep study, because treating sleep apnea is really important and can really help your quality of life. Pneumothorax or collapsed lungs is rare in Loeys-Dietz syndrome. I think in our experience, We see it more in Marfan syndrome, and we especially see it more in vascular EDS. We do appreciate in some of our patients who have been smokers that there's likely a greater and more severe risk of emphysema, which clearly we want to avoid because it can also really complicate surgical intervention recovery. So again, that public health message of please, please, please stay away from smoking. Something we also want to expand upon, and we just validate and appreciate that we know that fatigue, joint, and other pain can be quite an issue and impact quality of life. So we want to make sure we're addressing quality of life issues and making sure that we're addressing the mental health impact of living with or being at risk for aortic dissection or vascular catastrophe. So I think that was our whirlwind kind of trip through the 2014 guidelines and how we want to move forward and kind of readdressing things. We really, really want to thank you for all your great questions. We really want to go back through the chat at least and kind of pick out the topics that were really important. Angela, I know we kind of planned on going more than an hour, so should we pick out some of the questions from the Q&A and see if we can address some of those? Would that work?
Yeah, absolutely. And just so everyone knows, just to reiterate, if you need to jump off, this was scheduled for 90 minutes, but if you need to jump off at any time, this is being recorded, and we will be sharing that link out both through an email to everyone who registered and also through, social media channels and things. So, the floor is yours, Gretchen. So take it however you'd like.
Yeah. So Hal, maybe I'll just kind of pick a few questions out. Is that okay? And then
I've been trying to answer some along the way. So
if you go to the Q&A section, can you see that on the top and not just the chat where it has 23 questions? If not, one of the questions, I'll just kind of start picking some, is about, you talked about the meta-analysis, which was awesome. And then you touched upon adding a beta blocker. Can you just let us know what studies have said about the ARB plus the beta blocker showing additional benefit?
Yeah. So in the meta-analysis, sufficient information to document that angiotensin receptor blockers were protective in people with Marfan syndrome. Again, these trials were specifically focused on Marfan syndrome. You could indirectly make the inference that beta blockers were also effective, although there wasn't enough of a control experience to make that as an independent conclusion. The evidence strongly suggested that beta blockers and angiotensin receptor blockers showed a comparable level of protection. There was no evidence that the beta blocker and the angiotensin receptor blocker were dependent on each other or were using the same mechanism of protection. So it's a little bit of open to interpretation of the data. But there's at least the strong suggestion that the combination of both a beta blocker and an angiotensin receptor blocker might show greater potential for some people. So our general feeling is that you and your doctor should discuss these medications and come to a decision about which one you're going to use first. We would avoid using a little bit of this one and a little bit of that one. Our preferred approach is to pick one of the classes of medications, to fully optimize the dose of medication that you're receiving in that class, to then assess the situation and see whether there's still room for improvement based upon the pattern of aortic growth, and then to consider adding a drug in the other class of medication. But again, we would not favor giving a little bit of a beta blocker and a little bit of an angiotensin receptor blocker and assume that someone's getting any benefit from that approach.
And kind of along the lines of medication and that first question or that first slide, we were talking about non-penetrance. Can you talk a little bit just about your thought process when you're counseling families where someone in the family has aortic dilation, but the person in front of you has a normal aorta, but has the Loeys-Dietz gene? Like, how does that conversation go when they're thinking about should they use medication or not?
Yeah, so all decisions regarding treatment are based upon a risk-benefit assessment. We're always asking, what is the probability that this intervention is going to be beneficial? And we're always asking, what is the probability that this intervention will be well tolerated, that the medication, for example, is not going to cause a medical problem. Fortunately, both beta blockers and angiotensin receptor blockers have proven to be very safe medications. So there's really very little on the risk side of the equation when considering to use one of these medications. If someone comes to me with Loeys-Dietz syndrome and already demonstrating aortic enlargement, I would clearly favor moving forward with using a medication. If someone comes to me and they have the DNA change for Loeys-Dietz syndrome, and their family member with the same DNA change has already shown a significant aortic problem, my personal assessment is that the benefit of starting a medication at that point outweighs any risk of starting the medication. So my personal style is to go ahead and use a medication if the DNA change that's present in that individual has proven that it's capable of causing an aortic problem, even if that person is not yet showing an aortic problem. Is it possible that the aorta would never enlarge even without the use of the medication? Yes, it's possible. But given the low risk of use of these medications, I still think that the benefit outweighs any risk to start the medications early. Another important point is that many studies, many clinical trials in Marfan syndrome for medications such as losartan or beta blockers documented that the treatment effect was greatest the earlier the medication was started. So there seemed to be really good consensus on that fact that it's better to prevent aortic growth than to allow aortic growth and then try to get it under control.
Thank you. This is a good question I haven't seen before. Is there any precautions with arterial line insertion for anesthesia and the risk of arterial dissection in Loeys-Dietz patients? So maybe also like catheter procedures.
So the answer is yes. Anytime you manipulate an artery, there is some risk that the manipulation itself is going to cause arterial injury, and that potentially includes initiating a tear of the artery, such as a dissection. That is true even in people that don't have a connective tissue disorder. The risk is, I would say, increased in people with connective tissue disorders, but not high in Loeys-Dietz syndrome or Marfan syndrome. The risk is greater, for example, in people with vascular Ehlers-Danlos syndrome. So in that condition, you have to factor in the possibility that a catheter procedure is going to cause a problem to start. Again, the doctors caring for people with Loeys-Dietz syndrome or Marfan syndrome should be aware that that's a potential complication. They should weigh it into their risk-benefit assessment, but fortunately, the risk is not high.
So this would be a question I think two people have asked. Any thoughts on neuropathy in Loeys-Dietz syndrome and or, how that might impact pain management?
Yeah, so I would be the first to admit that we have a lot to learn about the causes of pain in people with connective tissue disorders. Sometimes the cause of pain is obvious, such as an orthopedic concern, but I would freely state that there are people that I care for and care about that have pain that I can't explain, and that we could do better treating if we did have an explanation. There are, in reflecting on the people we care for with Loeys-Dietz syndrome, there are some people that have what appears to be a peripheral neuropathy, pain in, for example, their feet that is poorly explained and not explained based upon vascular considerations. But again, it's not high, and I don't even think I have the evidence to state that people with Loeys-Dietz syndrome are at higher risk for neuropathy than people without Loeys-Dietz syndrome. So I've seen it, but I'm not sure it's actually part of the condition.
And any correlation or conversation about POTS and Loeys-Dietz syndrome?
Yeah, so POTS stands for postural orthostatic tachycardia syndrome. Basically, what it's describing is people that feel lightheaded and dizzy and might even pass out when they change position quickly. It's relatively common in all of the vascular connective tissue disorders, including Marfan, Loeys-Dietz, and multiple forms of Ehlers-Danlos syndrome. We do think that it's triggered, at least in part, by a sluggish response to low blood flow to the brain. That whenever anybody changes position quickly and sits up or stands up, their brain sends a signal that it wants more blood flow. In people that don't have connective tissue disorders, that's generally a very swift and well-coordinated response that leads to improved blood flow to the brain and no symptoms. In people with connective tissue disorders, that same response happens, but it's less well-coordinated and more sluggish. That can lead to overcompensation effects and heart rates that get too rapid and then plummet. We do know some things that help. So clearly keeping the tank full, staying well hydrated at all points in time will reduce the frequency or severity of lightheadedness or dizziness with changes in position. Some people respond to added salt in the diet. There are some medications that can be used to help with POTS that can include certain stimulant medications, can include beta blockers, and can include some medications that help your kidney hold on to more salt. That in effect keeps more fluid in your system. It's definitely something that you should talk to your physicians about because I would say we've been able to come up with an effective solution, if not cure, but at least partial solution for most of the people that we care for with connective tissue disorders and POTS symptoms.
Any evidence of prevalence of autoimmune conditions with Loeys-Dietz syndrome, like rheumatoid arthritis or other immunity, or I guess autoimmune conditions?
The answer is yes. I wonder if Tony might want to address this because it's in the expertise of some work that Tony and Pam, his immunologist wife, have been doing on Loeys-Dietz syndrome. So do you want to address that, Tony?
Sure. So we do know that the DNA change in Loeys-Dietz syndrome, it's present in all the cells. And we do know that the TGF-beta pathway is one of the very big pathways that affects how white blood cells act, how easily they are to excite, how they're able to be calmed down. And it's also part of the pathway that helps them recognize what is an invader versus what is part of your own tissue, or what's a protein from a food you ate, or protein from pollen that just happened to get stuck to the inside of your nose when you were outside. It does make the cells a little bit more likely to be activated. And so you can get an increase in cells being overactivated and recognizing parts of your body they shouldn't and triggering an attack against them.
Yeah, so that can include bowel, gastrointestinal inflammation, but we also have seen some people with Loeys-Dietz syndrome with other autoimmune conditions, including autoimmune thyroid disease and a number of others. So I think the answer is yes. There is evidence of a somewhat overactive immune system in some patients with Loeys-Dietz syndrome, and it is something that you should talk to your doctors about if there's concern about an autoimmune condition.
And Tony, while we have you here, there were a few questions about use of inhalers and Flovent and albuterol, which is kind of in your realm too, if maybe you can address that.
So inhaled steroids like Flovent or some of the newer steroids, those are all okay to use. And if your pulmonologist or your doctor who's managing your asthma thinks you should be on those, you should. For a rescue inhaler, like albuterol, we typically would suggest that instead of albuterol, you use a version of that called Xopenex. So albuterol has two very, very similar molecules in it. And one of them affects your heart more and one of them affects your lungs more. Xopenex only includes the version that helps relax your lungs and open them up, and doesn't include the version of that molecule that increases your blood pressure, increases how hard your heart is acting. So we typically, for people with asthma who need a rescue inhaler, we would suggest that you use Xopenex as opposed to albuterol.
Thanks. Hold on. I'm just finishing up a question. Oh, you guys have so many good questions. Watch out for neck symptoms. Okay. I'm trying to answer these at the same time. Let me see if there's anything else. This might be out of our realm, so maybe I'll defer this one, but if anyone has any thoughts on just osteoporosis or joint degradation we might see in Loeys-Dietz syndrome, and any type of supplement in terms of calcium or things like that.
Yeah, so Tony might have more to add, but certainly some people with Loeys-Dietz syndrome show reduced mineralization of their bone, reduced deposition of calcium that makes bones strong. Sometimes that can be severe and can make someone more likely to have a bone fracture, even with only a very minor injury. In people with Loeys-Dietz syndrome that have shown a tendency to fracture easily, we would strongly recommend visiting with a bone health specialist. There are physicians, largely endocrinologists, that specialize in bone health, and there are some medicines, including some very effective medications that can help improve the quality of the bone. There are other people with Loeys-Dietz syndrome that have very mild abnormalities of their bone calcification, something called osteopenia, rather than the more severe osteoporosis. We would want them to make sure that their level of vitamin D is optimized. We'd want them to make sure that they have good calcium intake. People with Loeys-Dietz syndrome should think about their bone health. Joints are in many connective tissue disorders are more prone to injury. A loose joint is more likely to undergo wear and tear. We do think that people should pay attention to their body, listen to their joints. If an activity causes pain or predictably causes pain or injury, they should avoid that activity. But the joint destruction that can happen in connective tissue disorders is largely related to a process called osteoarthritis. It's the wear and tear kind of arthritis rather than the autoimmune form of arthritis, like rheumatoid arthritis. So bottom line is pay attention to your joints, respect your joints.
Okay, I have two more questions, one for Dr. Dietz and then the last one I'll handle. But you guys make sure I put my email in the chat, but also please remember, for any questions that didn't get answered, or if you have any questions, make sure to reach out to the Marfan help desk. Because often what they do, Jan is awesome, but if she can't answer your question, it'll get forwarded to one of us and we get back to her. So make sure you utilize those help desk resources. Last question for you, Dr. Dietz. In terms of exercising, what are your suggestions in terms of kind of like heart rate recommendations, or kind of what guidelines say and how you think or feel about them?
Yeah, I want to begin by stressing that I want people with Loeys-Dietz syndrome to be active. I want them to be doing all sorts of moving activities on a regular basis. I would prefer if they were not exercising to the point of complete exhaustion, like running a competitive marathon, for example. But I would encourage people to be walking and swimming and jogging and hiking and bike riding on a regular basis. And if they were doing that every day and enjoying it, that would make me happy as well. We typically suggest that people avoid straining kinds of activities where you have to close off your upper airway and really grunt to finish the activity, where you're straining against a resistance, like weightlifting, but also like sit-ups, pull-ups, and push-ups, where you're straining against your body weight. During that straining, your muscles contract very tightly around the blood vessels. They cause the resistance in the blood vessels to go up, and they therefore cause the pressure in your arteries to go sky high. They even triple. The pressure even triples during that straining kinds of activities. So we would suggest avoiding that. We also suggest avoiding contact sports. That kind of makes sense, to avoid a game where it's expected that someone's going to hit you as hard as they can in the chest or in the head. That is both to protect the blood vessels, but also to protect the eyes in people with connective tissue disorders that can be prone to something called retinal detachment. With regard to how much exercise is okay, I don't think anything ruins the enjoyment of exercise more than taking your pulse every 5 minutes while you're exercising. So I think a good rule, a rule that we generally recommend, is that if you can carry on a comfortable conversation while you're exercising, if you don't have to take a breath in the middle of very short sentences while you're exercising, then you're in a good place. If you're taking very frequent breaths, can't carry on a conversation, or can't talk because you're straining and grunting, you're pushing things too far. So we generally recommend that people just use that basic rule, be able to carry on a comfortable conversation.
And the last question for the evening that I wanted to address was a question that is near and dear to my heart, asking about anxiety in children with Loeys-Dietz. So, you know, this hasn't been well studied in our kind of population. I wouldn't say that like underlying anxiety, depression is increased compared to the general population. However, our patients have tons of reasons to be anxious, to have depression, being in community with friends who have complications, their own health complications, their family history of health complications. So we take mental health very, very seriously. And in fact, studies have shown that at least in aortic disease populations, there's about a 30% prevalence rate of anxiety, depression, and post-traumatic stress disorders. And the post-traumatic stress can also be caused by medical issues and chronic diseases as well. So we always recommend that in our adults and in our kids that you're really in tune to making sure that if any psychotherapy or any type of medications needed to be used, you know, Dr. Dietz always says that our job is to help you have a long years of life, but we also want to make sure that they're a good quality of life. So making sure that you address any of those needs. And we, Dr. Gurio and I and colleagues from Keck, USC in California, received a grant to provide a mental health resource, mostly geared towards adults, and then do research studies to kind of look at some of the mental health topics in this population. So you can look forward to that launch later this summer. It's a really important topic and one that I know the Marfan Foundation and Loeys-Dietz Syndrome Foundation is really dedicated to. So you can check out, and maybe Angela, if you want to drop the link to the new mental health resources through the Marfan Foundation, there is a mental health task force through the Marfan Foundation that is really working to put together great resources, blogs, et cetera, et cetera. So with that, I thank you guys so much. This has been really fun and informative, and I hope you have enjoyed it as well. You've given us a lot of feedback to think about and helping us take better care of patients. But Hal, if you have any last words, I just thank everyone for participating tonight.
No, just look forward to hearing your thoughts and helping us come up with the best guidelines possible. And we'd be happy to try to address any unanswered questions. So don't be shy about sending them along.
So I want to jump in and say thank you to all three of you. I just had a moment here where I just went, all of us in attendance here are just sitting in so much wisdom and greatness of the three of you, and all your expertise. And I can't ever express enough gratitude for you taking the time to spend this 90 minutes with us and share all of that. It's been super valuable. I can tell just by the comments and by the questions how in depth that we've been able to go in this conversation. So thank you, Gretchen, Hal, Tony, all of you. You're just rock stars, and we're just happy to be in the midst of it, I think. So just a couple of things I wanted to note. Again, if you are in need of assistance for any topic, including what we talked about this evening, please do contact our helpline. I dropped the link in the chat, but it's loeysdietz.org/ask. And then also I dropped the link on the Marfan Foundation's website for our mental health resources page. It is growing. More information will be there as well. If you missed the link, you can go to marfan.org, just type in mental health and that page will come up for you. Other things I just wanted to mention, if you have not signed up for annual conference coming up in July, that is at marfan.org/conference. We would love to have you join us. All of the faces you see here before you tonight will be there for at least some portion of the conference, and we would love to meet you face to face and answer any questions you have then. So with that, I know we could go on and on and on, but I am just, again, thank you for this time and for sharing this this month too. It's a busy month, but it's Loeys-Dietz Awareness Month. So thank you and for helping us celebrate. So with that, everyone have a great evening and thanks
you.
again.
Bye-bye.
Bye.
Bye, everyone.